Without any further ado, I'm going to bring in Dr. Paul Pepe, who's been a mentor to me and many other people across this country in this field of EMS. So, Dr. Pepe, can I have you share your screen?
Anyways, whenever I had to make a decision about what our protocol would be or what decision I would make in a particular patient on scene or whatever it may be, or in the emergency department, I'd always say, if this was my family member, if this is my daughter, if this was my brother, what would I do? And this is, you're going to see, this is what I would do as we get along here, particularly with respect to TXA. All right, let's roll. So as I call it, transition to tranexamic acid. And I was supposed to give this originally at the Eagles meeting, and we never had a chance to get it. But and I was going to come on as Dr. Reddy Whip there, so we'll see how it goes. All right, so disclosures, right? All the coffee beans, Columbia wouldn't make me a morning person. That's the only disclosure I have, and I'm non-essential as well, as everyone knows. We actually published on this with John Jew and John Holcomb a few years ago about non-mechanical hemostasis in trauma. And that included various things, not only giving blood, but also giving TXA as well. And we then later did an update on TXA and TBI. The bottom line here, and Jim Roach, who of course has been so instrumental down here in South Florida, getting things going here with blood, was on that with us. And bottom line was, it really is, it's nothing has changed in my mind since then, and no other data have come up to change what I'm about to tell you. Okay, so Json published the TCCC proposed change in 2022 for 2022 guidelines, where they said down the below the most significant updates to the guidelines are including significant traumatic brain injury as an indication for TXA, and I will mention that today. And although we're focusing on hemorrhaging patients and so on, this goes hand in hand with the hemorrhage guidelines as well. And the issue is to change the dosing as a single 2-gram IV or IO administration. And then we're recommending it, as a slow IV push. And we all have made different interpretations of what that is as we get along here. So this all got started with the CRASH 2 study many years ago, published back first in 2010. The thing that's interesting about this paper is that their protocol said that what they did was they randomized people within 8 hours of injury, and they had a loading dose of a gram over 10 minutes and then 1 gram over 8 hours. This is going to be the key point. This all got started because people would give a loading dose when they were doing some cardiac surgeries or other types of surgeries back in the 60s. And then they would give this over the next period of time while they were still operating, et cetera. So the interesting thing is that that's what people have used to apply to trauma, which we, in retrospect, think was not a good. So when you hear about me talking about the 1+1, I'm talking about 1 gram up front and then 1 gram over the next hour, several hours. In this case, you see here that they also went out to 40 countries, and they actually found a difference. Now, the differences were very small in terms of the outcomes, but there was some positive difference. I'm about to tell you why they had some positive difference, because they gave it, just not to bury the headline, when they gave it very early on, that's where the better outcomes were showing up. And I'm going to show you that here right now. So overall, they said, hey, we had better outcomes here. As you see, for bleeding deaths, early TXA treatment is better. And on this side, this is better outcome versus worse outcomes on this part of the slide. And Peter, can everybody see this okay? Am I showing you the right?
Yeah, looks perfect. Yep.
Okay, good. So this is the overall outcome. And that's the problem. People always take the bottom line, the yes or no line, without looking at the data and breaking it down. And so what happens is it turned out that if you actually, if you actually got treated within an hour, look at this, your chances of dying was 0.7, like 70%, 0.7 chance of dying over, let's say if it's a 1-to-1 ratio, you're saying your chance of dying is only 2/3 of that, of what it normally would be. And so that's what pushes, but that means this is a balance of something else, okay? And that balance of something else was that over 3 hours, if it was given late, you had worse outcomes. Now, why would you have worse outcomes? And again, we're going to talk about that in just a second. Well, the worse outcomes is attributed to the fact that it's a thing that causes you to clot. And if you live long enough to have clotting associations, you'll have risk of problems. And this is what's interesting, is because at first, many of the surgeons had been not accepting it, whereas military people, where many our trauma surgeons weren't, because when they did the studies in the hospital, a person lived long enough, they actually had more, they started seeing these complications, all right? So, and that's totally understandable. And again, where I'm going to be going to is that if you give it early, and I mean really early, it's a good thing. There may be some complications, but you will have a better chance of living if you're in a position where you have to get this. It's that if time goes on and you give it later, then the risk-benefit ratio flips, where risk is now much higher, et cetera. And that's going to be my main theme here, but I'll go ahead and give you some of the data, all right? So again, let's go back to this. If you give it here within an hour, and that is what made a difference. So which way do we go? All right. The really cool thing is that we started understanding this, and right about that time, people like Dr. Marty Shriver, who did a study on head injury cases, following one also that was called Crash 3, by the way, which showed kind of similar results. It sort of kind of, yes, it was a little bit better, et cetera. But what really came down to when Marty did his study with the ROC, Resuscitation Outcomes Consortium, he prospectively asked, we're going to see what happens if you had a person with a head bleed. In other words, if you later document they have a head bleed, let's see how they did in terms of their survival, et cetera. All right. And that's Dr. Shriver right there. So this study, published again in the JAMA, overall didn't show a real significant difference between it, because they lumped everybody together. And one of the things I'll tell you is that they lumped the 1+1 grouping with a 2 grams right up front group. So everything was kind of mixed together in those two groups. You'll see why that becomes really important as we go along here. But when they did look at the specifics thing of this 2 grams versus 1.7 versus placebo, so they had the wisdom to look at this in terms of 3 arms. You lose a little statistical significance, but still 2 grams versus 1+1 versus placebo. And they looked at moderate to severe TBI cases, in this particular situation. What was interesting is the median time, that means half the people got it within 40 minutes of the time of the injury. So that's pretty significant. And it goes along with the line of what I've been thinking, what the TCCC people have been thinking, that, my mantra has always been the earlier the intervention, the better results. And this was getting that's pretty good to get it in half the patients with that period of time. So, and the other thing is that nearly 60% of the people later were found to have an intracranial bleed. And then, of course, that meant there was 44% without, which, by the way, is a nice built-in safety cohort. In other words, they didn't have any bleeding in their head, and yet they got this and didn't hurt them. And just to jump ahead, it was perfectly safe to give it to them under these circumstances. They didn't have more complications or anything like that. So the overall results, again, were 65% plus versus 62% for the controls. But remember, the 65% thing lumps both the people with head injury, with head bleed, without head bleed, and also it lumped in the ones that got the 1+1. They just lumped them together in that primary thing. But when you examine those with CT confirmed intracranial bleed, the target group, from my point of view, right, there was a 16% mortality with the 2 grams up front. Okay, and look at this. When you looked at 27% with the 1+1 infusion versus 26%, so mortality rates were about the same for the placebo plus the 1+1 gram versus the 2 grams up front. And this really started pushing me even further to being aggressive about, let's say, if it's going to be more than an hour, I may not even want to give it. And certainly I don't want to give an infusion over the next 8 hours. If this was my family member, this is how I feel at this point in time. There was a slight risk of more seizures, but you have seizures anyways. It's like, they had 13 seizures versus 8 seizures out of the 300 patients that were being examined. But there was no other increase in complications, and it was they did fine long term, and so it was deemed to be safe from that point of view as well. So let's go back to this. What it really tells us is that this thing is what we need to concentrate on, the less than 1 hour thing. Early treatment, less than 1 hour is much better. And avoid going, by the way, here. And particularly, I'd like to avoid going anywhere out towards over an hour from my point of view, right? So now when you look back at Crash 3, under that circumstance, same kind of stuff starts showing up, that your chances are dying. This is like 60%, there was 40% less. It was only 60% of what it normally would be. And especially if you got it done, this is treatment, within the first hour here. This is minutes to treatment. So they did have a relative risk ratio that was much better. The earlier you gave it, the better off you were. In the ROC study that I just talked about there, what was interesting, the early time, less than an hour to therapy with 2 grams improves the outcomes pretty significantly. And so that's what you see down here. Now, this is a time in days. So we're talking about the hour thing is in here, but you can see this is extremely low when you get into this, first quarter hour, half hour, hour period here, et cetera. It's all showing the same thing. This is the bolus only group, the 2 grams IV up front. And now here's your mortality rates out here with the placebo and the bolus maintenance group. All right. So when the STAMP trial came out with Frank Guyette and his group out there, same kind of stuff shows up. favors transact. They gave 1 gram and then they gave 1 at the arrival at the hospital, which generally there was within about an hour, by the way, they pointed out to me. And again, all this stuff started favoring the transexamined group here. And the same thing, if the time from injury is less than an hour, they did better. And then if the blood pressure is less than 70, obviously the people who are sicker, much better, etc. So better with higher dose, better with treatment within an hour, and especially if you presented with hypotension. So anyways, when the article that just came out about a week ago out of, you might ask, well, what did they find there? One of the interesting things about the patch trauma group, which came out of Australia primarily, I knew the results of this, by the way, about 8 or 9 months ago, because they consulted with me and talked to me about it because they were getting ready to write the paper up. And I said, before you tell me the results, I just want to know one thing. What was your protocol? And they said 1 gram IV followed by 1 gram infusion. I said, you're not going to find any difference, or it may even be worse for all I know. But and it depends. And it turns out only about 20% of their people got the drug within the first hour, by the way, in this study, let alone the fact that they did the protocol with a 1+1. There was not the 2 grams up front. And as predicted, it didn't show any difference of that kind of thing. So it was very, very interesting that they said, right now, I was able to predict what their outcome was going to be without them telling me, just based on that alone. So in summary for the TXA, and I hope I haven't gone over too long here, Peter, is that there are better outcomes, but only if given early as a 2 gram bolus, as far as I'm concerned. It's safe if it's given early. And also, it's likely good for all trauma, including internal bleeding and TBI cases. And then we can talk later about giving it for other bleeding cases, obstetrical, and so on. But that's the reason why most of our protocols down here in South Florida do go this route. I know you mentioned San Antonio, and there's so many others. That's the same way we've been doing it, the same approach here. And by the way, I haven't seen any particular issues coming out of this that have been a problem that we have to note. Someone will have to clue me in if there isn't anything else to be noted about here. So again, coming back to it, 2 grams IV IO administration. Some people have asked me, by the way, about giving IM. And one of the things that a lot of us worry about there is, I guess it's better than nothing if you're in a tough situation where you're, for example, I don't know, pinned in a tactical situation. But your blood flow may not be so good, so maybe it doesn't absorb as well. Those studies are actually kind of going on. They may already be published, and I don't have the data, but that's one thing. The other thing is that places like San Antonio actually will give it early on. Just it's a logistical thing, because as they're getting the blood up and ready to go, they want this on board as soon as possible. And we try not to mix the two. And I think that's pretty much what I want to say about that for now. And then Peter, can you just add in TXA for kids? Should we not give it to kids? Should we give it to kids? What's your protocol say?
You could probably guess that we do give it to kids. We treat them just the same as everybody else. Nothing magical happens when you turn 18. So yeah, we give 15 milligrams per kilogram. And there's lots of data on that. And actually, the data from the military demonstrates that TXA in children does have a positive impact, a reduced mortality. So just like with whole blood, please have a whole blood policy or protocol for children. And also, if you're using TXA, do not exclude the kids as well. So that's my 2 seconds on that.
So Peter, you have a protocol, I think, starting around age 5 or something like that. How about if it's a 3-year-old, and they're bleeding, and it's not good? They
Yeah,
got
so
by accident on the beach, whatever, that kind of thing, right?
the protocol allows for whole blood in all ages. It's just that, and we're not a mother may I call the medical director type of people, but for this particular thing under the age of 5, it's just a call to the medical director. The dose is still in the app. And so, before launching this protocol, I looked at 5 years of data from our children's level 1 trauma center. And in 5 years, we didn't have one child who needed blood in the trauma bay under the age of 5, although there are stories from other places that do have that. So it's not that we exclude under age 5, it just requires a call just so we're aware of what's going on.
And that's for TXA as well, though? That's what I was asking.
No,
Huh?
No.
Okay.
No.
That I just wanted to ask that. All right. Does anybody have any questions of me? Do you want to?
Yeah, Paul. Let's keep going only because we have a tight agenda. So if you want to do the calcium, then we'll ask questions after you do the calcium.
Okay, good. I'm fine with that. I just want to make sure if anything wasn't clear here, let me know. Okay, so thanks. So in conclusion, I think we're going to get back more people than we did before. So how about giving that pre-hospital with transfusions? So what I'm going to do is, why would we do this in the first place? 2, should we use calcium chloride or gluconate, and what route should we use? IV, IO, IM. Pros and cons on doing it pre-hospital versus in-hospital. And then some of the general questions that we won't address so much today, but just to know there are effects on the heart, phosphate levels, the microcirculation and various things that we have yet to explore. And there's even more things we're going to talk about in terms of trauma itself causing hypocalcemia. All right. So let's go to the why. So the why is that things like EDTA or citrate, which are calcium chelators, are used to stop the clotting of stored blood. If you absorb up calcium, you actually create a more of a a less coagulated environment. So these numbers might be wrong depending on what situation or what it is, but there's a certain amount of this stuff is added into it. So usually they'll give you 3 grams of citrate or 1.6 citrate plus some other calcium binder, and that's it. And then of course, if you have to then break it down further, like into RBCs, they might have to add, let's say, 40 mils more, so that's 80. And if you're given 2 packs of red cells, then you might be giving a lot of citrate. And it depends on the formulation. Like for example, if you're having one that lasts 30 days, you might have more. So those are all things that are right there. And in fact, I know, Randy Schaefer, if I could make like a 10-second intro, isn't that sort of the case from what you found is different? There may be, depending on how long they want to store the blood for, there may be different dosing of these kinds of chelators.
Yeah, if it's CBD versus CPDA1, and the first one is usually a 21-day life cycle, and the second is a 35-day. I do not know enough about the difference, but I'd be curious to see if there is some. So I'm going to start looking that up.
I would just say that the main thing is be aware of this, by the way, and you might want to find out in your area, what they're using and how they're using it, et cetera. So just bottom line, though, it doesn't matter. It's lowering the calcium. And once you get to your bloodstream, it lowers it even further. All right. And then also there's free floating citrate in your bloodstream. So, and what happens if you're injured, like you have a damaged or poorly perfused liver where it's usually metabolized, the levels of citrates, for example, could go up, and then you have toxicity from it in the sense of really taking out more calcium, et cetera. So you got the general idea is that you are at risk for it. But the interesting thing is that you actually can get it from the trauma itself. Now, I'm not absolutely sure why this happens. My personal belief is that it's related to the fact that when you get into an acidotic state, you're producing a lot of H positive hydrogen ions. And so it competes with the calcium, may drive it down. And so as a result, you may have, there may be other reasons that I haven't delved into yet. I'm just learning more and more about this. But even so, without giving the blood, you can find that you're hypocalcemic in some of the cases that we're talking about here who are at risk. So a concern. So more and more, I've been thinking this is what we need to do. But what's the treatment? Should you give calcium chloride or calcium gluconate? Well, it turns out that in theory, anyways, calcium chloride might be better because you get better free calcium ions out there right away. Or is that a problem, actually, you know, because you affect other things? Because once you put calcium out there, you will affect potassium levels, you'll affect all sorts of other things as well. But probably in this case, because you're so hypoglycemic, de facto, whether you've had blood or not, is probably, you know, it says that takes some of that worry out. But there also is a risk for sclerosis, meaning that if you get it into like a peripheral IV site and it extravasates, leaks out, you could cause really bad sclerosis in that area. And then, Peter, you have a case in which it was an injury to the leg, but they just did they give it into a vein in the leg, or how happened? But I heard that there was cases where at some hospitals they had an amputated kid's leg when they gave this, and so as a result, they've switched over to calcium gluconate altogether. Is that right?
Yes, that was a pediatric patient, and the child did indeed require an amputation. So they just
was it a leg or an arm? I'm sorry, I didn't know about the amputation. I'm sorry that I didn't know that. I was just thinking badly leg, but it probably was arm, right? Where they probably gave
it was a leg.
Oh, and they were they gave the IV or whatever through the leg, or did it?
I'm not sure if it was a central line or an IO, but it was right lower extremity.
Right. Anyways, but you know, theoretically, if you get a good IO in, by the way, it's fine to give it that way. There's not a problem with this, you know. And then, of course, we have emphasizing femorals and humorals maybe in adults. But here's the problem: did you get it in? Did you get it in the right place? Will it cause a problem like we've seen here that we're not sure about? So there's a lot of questions out there about this. Okay. So bottom line is that when you look at the joint trauma system, recommendations anybody can look up. Here's their quick reference guide, and I'll pull it up a little tighter. It says to prevent hypocalcemia related to massive transfusion, monitor ionized calcium, administer it early, etc. But just jumping down here, it says that calcium gluconate is preferred for peripheral IV administration. In other words, that you really have to have a good central IV in if you're going to give it calcium chloride. So we may be saying that may be the way to go, and it may be the preferred way to go under these circumstances. Okay. All right. So now what's the pros and cons of pre-hospital? So most of us have thought, hey, let's just get it when we get to the hospital because we're only given a unit out there. But when you consider the fact that maybe you're just getting hypocalcemia from the trauma itself in these patients, maybe that gives you some pause and think maybe immediate treatment is good after all, you know, versus the hospital arrival where you can get a central line in, all those kinds of things. But one of some people would cite, and I don't know if David Miramontes or CJ could comment this, is that part of it is also you need an extra IV. So it's the logistics and maybe it's the time issue, and let's just do it later on or go in hospital. And then in the hospital, you'll have the ability to check for calcium, phosphate levels, potassium levels, and all that. And someone would say, by the way, there's no proof that gives you a better chance of living. They give it pre-hospital. I think there is enough data, and we're going to send you some papers to say your chances, if you let the calcium go, if the persons have hypoglycemia, it's associated with death. So presumably treating it would be a good thing. But so giving it pre-hospital, does it make a difference? We're not sure yet. But I'll tell you what, as I've learned more and more about this over the last few days, and I'm going to learn more and more, I'm leaning more and more towards giving it in that pre-hospital setting if it doesn't delay things, and using gluconate so we avoid all the other hassles that we were just talking about with the calcium chloride. So in conclusion, the answer is do give it pre-hospital or don't give it pre-hospital. And that's everything today. If you're giving it, like Eric Bank, I think, is on the phone, that you guys have been giving it for IV calcium chloride for years. So the bottom line is that you could give it, and I wouldn't have a problem with it, and if you wait till the hospital right now, I don't have a problem with it. Although I will admit, when we talk about which way do we go, I'm starting to lean more and more pre-hospital, as I always have.